To our cardiovascular physiology revision. So we have here 80 MCQ questions, which all related to cardiovascular physiology. So it will provide you a good comprehensive understanding for essential topics in cardiovascular physiology. So we have questions related to the initiation of cardiac impulse, how it is conducted in the heart, then how it is recorded, so in the form of ECG, then how the heart contract and relax, the different phases of cardiac cycle, and the pressure volume changes which accompany each phase. Then we will be talking about the cardiac output, which is the volume pumped by each ventricle in a minute. This cardiac output is an essential parameter in determining our blood pressure. So we'll be talking about also blood pressure. Then we will be we have also a set of questions related to heart sounds, normal and abnormal heart sounds. We'll focus on murmurs associated with valvular diseases and valvular abnormalities. Then we also have a set of questions on coronary blood flow and its regulation. So let's start. So we have here our first question, which is quite straightforward. Which ion is primarily responsible for the depolarization phase of the cardiac muscle cells? For the depolarization of cardiac muscle cells, we know that cardiac muscle has the action potential of cardiac muscle has 4 phases. Phase 4, that is the resting membrane potential, followed by phase 0, which is the depolarization. And the depolarization in cardiac muscle is caused by sodium ions. So influx of sodium ions causes the cell to depolarize, means there will be decrease in membrane potential. And that decrease in membrane potential, we call it depolarization. So this action potential happens quite quickly, and that's why the depolarization phase is very fast in the contractile fibers of the heart. What is the primary role of EV node in cardiac conduction? So if we look here at this figure, we see the conductive system of the heart. So we see here the SE node where the impulse is generated. Then the impulse is conducted to EV node, then to EV bundle, then bundle branches, right and left branches. Then we have the Purkinje fibers. So EV node is this one. So the role of EV node is to conduct the impulses from the atrium to the ventricles. So our correct answer here is conduct impulses to the ventricles. Initiation of heartbeat, that is wrong because SC node is the one to initiate the heartbeat. Regulation of heart rate, again, this will be the function of SC node because this is the rate of the heart. The rate of the heart depends on how many impulse generated from SC node. So the role also in regulation will be SC node action potential. Transmit impulses to the atria, of course no, because it transmits the impulses from atria to the ventricles. What is the function of the Purkinje fibers? So Purkinje fibers, these are the small fibers which arise from the 2 bundle branches, and these fibers transmit the signals to all myocardial ventricular fibers. These fibers have very fast conduction, and that to make sure that the all ventricular cells depolarize at the same time and repolarize also at the same time. So the action potential reach to all these cells at the same time to make then they can contract together. So the main role of it is to rapidly conduct the impulses through the ventricle. The rate of conduction in Purkinje fiber is 4 meters per second. This is the fastest part in the conductive system. So the fastest part of conductive system in the heart is the Purkinje fibers. The plateau phase of the cardiac action potential is primarily due to the influx of which ion? Plateau. So plateau phase, if we look here, this is the action potential of the cardiac muscle cell, the ventricular contractile fiber. So we have resting membrane potential. We have depolarization caused by influx of sodium ion. we have triphasic repolarization. So this is phase 1, which is because of opening of potassium channels and potassium efflux. We have phase 2, that is the plateau phase. That is caused by calcium influx, which balances the potassium efflux. And that causes no changes that we see here, which is the plateau, no change in action potential, which is plateau phase. Then with calcium channels close and only potassium continue to flow out, causing the phase 3 repolarization. Then we have resting membrane potential. So the main reason for plateau is the influx of calcium ions, which balances the efflux of potassium. So potassium go out, balanced by calcium in, and that causes a plateau. Positive, balance positive. That plateau is quite important in the cardiac muscle. What is the significance of the long refractory period in cardiac muscle? We know that cardiac muscle has long refractory period. Refractory period means the cardiac muscle during that period will not be able to respond to any further stimulation. So that will give the heart sufficient time to contract and relax. So during a contraction, the heart cannot respond to any other stimulation. And that will protect the heart from tetanus, which is a condition where there is continuous contraction, there is no relaxation. So the heart will be protected from that because of the long refractory period. So the correct answer here, it prevents tetanus. Increased heart rate, that is of course wrong. Heart rate, the change in heart rate is related to the action potential of the pacemaker cells, not the contractile cells. We have two types of action potential in the heart: autorhythmic cells action potential, the pacemaker action potential, and contractile cell action potential. So when we talk about refractory period, we are talking about the contractile cells. Decreased contractility. This is the action potential doesn't have anything to do with the duration of the contractility. So normally the muscle depolarized, and during depolarization it contracts. While it is depolarizing, contraction is happening. And that is the reason why during contraction, the muscle is in absolute refractory period, because it is still in depolarization and repolarization. It's short in heartbeat duration, as I mentioned. It doesn't have anything to do with the heart rate, because heart rate is related to pacemaker action potential, not ventricular muscle or contractile fiber action potential. So this question is quite important in cardiac muscle physiology. So here is the quick review of the difference between skeletal muscle and cardiac muscle action potential. We see how short is the action potential of the skeletal muscle. So the muscle regain full excitability during a contraction. So if the muscle receive like another second stimulus, they can actually respond to it and they can continue contracting. But in the heart, we see here the action potential is long, much longer as compared with the duration of the action potential of skeletal muscle. So this long duration of action potential makes the refractory period also long, and that causes the muscle not to respond to any stimulation during contraction, and that prevents tetanus or continuous contraction of the cardiac muscle. All right, so now we can answer this question easily. So cardiac muscle is non-fatigable and non-tetanizable, and that is best explained because of course, presence of plateau. Okay, less presence of plateau, which makes the action potential long. So I have here like quite a number of questions about this part because it's quite important concept related to cardiac muscle physiology, as cardiac muscle is non-tetanizable and non-fatigable. And the reason for that is because of long refractory period, which is caused because of plateau, which is caused because of the opening of calcium channels and the calcium influx, which causes which balances potassium efflux. So these are the important information related to this part. All right. What effect does sympathetic nervous system have on the heart rate? So for sympathetic, we know sympathetic is for fight and flight, and sympathetic activate the heart, increase heart rate, increase contractility, increase conduction in the conductive system. So if we look at this option here, we see that option B is the correct option. So sympathetic increase heart rate. If I asked you how does sympathetic do so, remember to talk about the pacemaker action potential. So if we look here, we see the pacemaker action potential. So that is the action potential in SA node. So SA node action potential, we see what is known as pacemaker potential. And this part is the action potential, depolarization and repolarization. So pacemaker cells, they don't have resting membrane potential, but their membrane potential depolarizes spontaneously, and that is known as pacemaker potential. This part here, we call it pacemaker potential. This pacemaker potential is caused by number of reasons. One is because of influx of sodium ion through the funny sodium channels, and because of decreased permeability to potassium. So potassium is kept inside the cell, doesn't go out. That will increase also the positive ions inside, and opening of transient calcium channel, or T-type calcium channels, which allow calcium influx. So you have three ions responsible here for that pacemaker action potential: the sodium influx, calcium influx, the later part is calcium influx, and the decrease of the permeability to potassium. Then you have depolarization. This depolarization is caused by influx of calcium. Then we have repolarization, which is caused by potassium efflux. So here is potassium, here is calcium, and here is calcium and sodium and calcium. Sodium early part, later part is calcium. So what you see here, you see what happened to the pacemaker action potential here. It gets longer. It takes longer time. That is the effect of parasympathetic. If you look here at this graph, we see it's getting shorter. Getting shorter, that is the effect of sympathetic. So sympathetic nervous system increased heart rate because it actually decreased the slope of the pacemaker action potential. Decrease the slope of pacemaker action potential because it increased the permeability of the pacemaker cells to calcium. Okay, coming to this question, a 25-year-old man who has just finished a 30-minute treadmill exercise feels his heart is beating faster. The reason for that is he has just finished an exercise and he noticed an increase in his heart rate, and you need to explain the reason for that. So the reason for that, is it increase in permeability of SA node to calcium, or is it increased force of contraction, or is it decreased number of gap junction, or delay in node? So anything related to heart rate, it has something to do with the SA node, because SA node is the pacemaker of the heart. That is where the impulses are generated. So when the permeability increase to calcium, means more calcium will get into the cell, and more calcium means positive ions, so that will cause the depolarization, the pacemaker potential to happen faster. And that is the mechanism, as I mentioned earlier in the previous slide, for sympathetic stimulation. It actually increases permeability of the pacemaker cells to calcium as well as sodium, and that causes the depolarization to happen faster. Other reasons, they don't have anything to do with the rate. Question number 9. Which of the following represents secondary pacemaker of the heart? We have a hierarchy in the heart for autorhythmic cells. So autorhythmic cells, these are the cells which are able to generate action potential in the heart. And they are SA node, EV node, bundle of Hess, Purkinje fibers. So in order, SA node has the highest rate of impulse discharge, followed by EV node, come number second. So this is the highest. This is then EV node, then Purkinje fibers. So this is primary, secondary, and tertiary. So if any problem happen with SA node, then EV node will take over and becomes a pacemaker of the heart. And in that case, we call it secondary pacemaker. If EV node is damaged, in that case, Purkinje fiber will take over. But Purkinje fiber, the rate of impulse discharge is there, is quite slow, is incompatible with life. So here we are asking about the secondary. So the secondary pacemaker is EV. That is the second highest rate of impulse discharge in the heart. What is the effect of acetylcholine on the heart rate? So acetylcholine is the chemical transmitter, that is the neurotransmitter, which is released from parasympathetic fibers, which supply the heart. And acetylcholine acts on muscarinic receptor in the heart and causes decrease in heart rate. So the correct answer here is decrease in heart rate, because this acetylcholine is a parasympathetic supply, is a neurotransmitter of parasympathetic supply to the heart. So it decreased heart rate because it actually decreased permeability of pacemaker cells to sodium and calcium, and increased permeability to potassium efflux, causing hyperpolarization. All right. So now we proceed with a set of questions related to ECG. ECG stands for electrocardiogram, and this is the record of electrical activity of the heart, which actually a sum of the electrical activity of all cardiac muscle cells. So all cardiac muscle cells, each one has the action potential that we have seen, the 4 phases, phase 4, 0, 1, 2, 3. Okay, but in ECG is just the sum of the action potential from all cardiac muscle cells. We use electrodes, which we place it on the chest, and we attach it to the arms and the legs to record the ECG. So we have like 12 leads, the standard 12 lead of ECG. So we have lead 1, 2, 3, AVR, augmented vector right arm, augmented vector on left arm, then augmented vector on left foot. So these 6 leads, we call them together limb leads. Then we have another 6 leads, which are known as chest leads from V1 to V6. Okay, so all the chest leads are unipolar leads, and EVR, EVL, EVF are also unipolar, and 1, 2, 3, they are bipolar leads. Okay, so we have here first question in ECG. What does B wave represent? Okay, this is a very basic and important question in ECG. So if we look at ECG, so for ECG, we have waves, so like deflections. So we have B wave, QRS complex, and T wave. And some leads, some ECG recording, we can have a U wave. So B, QRS, and T. B wave refer to atrial depolarization. QRS complex ventricular depolarization. T wave ventricular repolarization. Remember, when we talk about ECG, we don't say atrial systole, ventricular systole. We say depolarization and repolarization, because ECG is a record of action potential, is a record of electricity, not record of mechanical activity. So it represents depolarization and repolarization. So for atrium, we have only one wave. For atrial depolarization, that is B wave. QRS complex ventricular depolarization. T ventricular repolarization. You might ask, where is atrial repolarization phase? Atrial repolarization phase happens during the repolarization of the atrium happens during the occurrence of QRS complex. So it's masked by the big QRS complex wave, which represents ventricular depolarization. So B is atrial depolarization. Atrial depolarization happens immediately before atrial contraction. What does QRS complex? Just now, okay, QRS complex represent ventricular depolarization. Ventricular repolarization is a T wave. Atrial depolarization is a B wave. Atrial repolarization happens during QRS complex. So QRS complex masks the wave for atrial repolarization. On an ECG, what is the normal range of BR interval? So BR interval is something that is very important to note in ECG. BR is indicate the time for impulse to be conducted from atrium to ventricle. Because B is atrial depolarization, QRS is ventricular. So BR interval refer to how long does the impulse required to be conducted from atrium to ventricle. So short BR interval means there is fast conduction, and long BR interval means slow conduction. And long BR interval considered as a first degree heart block, where there is a delay in the conduction of impulse from atrium to ventricle. So what is the normal duration of BR interval? Normal duration of BR interval is 3 to 5 small boxes. The ECG strips have small boxes and big boxes. So you count 3 to 5 small boxes from the beginning of B wave to the beginning of QRS complex. So let's look at this example here. So we have B is here. So this is B wave. This is B wave. This QRS complex. So the BR interval means from beginning of B wave to the beginning of QRS complex. So we count here how many small boxes. So if we count here, we have 4 small boxes. Each small box is 0.04 second. So if we count it here, it will be normal. It's 4 times, so it's 16, so 0.16. So the normal duration is 0.12 to 0.2 seconds, which is 3 to 5 small boxes. Here is 4, so it's considered normal. If it's less than 3, it's fast conduction, tachycardia. More than 5, it's considered as bradycardia or first degree heart block. Which lead on a standard 12 lead ECG best view the lateral wall of the left ventricle. We have 12 leads Okay, looking at the heart from different angles, different views. So if we put all of them together, the chest leads, they actually look at the heart on its horizontal plane. So the depth of the heart. So we have V1, V2, they look at the septum of the heart. 3, 4, anterior surface. 5, 6, lateral surface. That is from the chest. If you look at the limb leads, okay, you see here lead 1, EVL, they also lateral. So we have here lateral, we have here lateral. That is the lateral surface. So V5 and V6 along with lead 1 and EVL, they look at the lateral surface. They give you an idea about the lateral surface of the heart. V2, 3 and EVF, inferior surface. So inferior surface, 2, 3, EVF. Lateral surface, V5, V6, lead 1 and EVL. Anterior surface, 3 and 4. Septum is 1 and V1 and V2. So here is which lead looking at the lateral wall. So the correct answer here will be C, lead 1, EVL, V5 and V6. That is quite important because if there is ischemia or infarction and you want to know which surface is affected, you look at which lead shows the abnormality, which leads shows the abnormality, and from there you can know the surface. So in a normal ECG, what does T wave represent? T wave represents ventricular repolarization. So the correct answer here is D. What is the significance of an inverted T? So normally T wave is positive wave in most of the leads of the heart. So if you see T wave in a state of being like that, it becomes like this, okay, inverted T wave. So inverted T wave indicate which one of it. Is it almost normal? Of course, no. Indicate atrial fibrillation. Again, atrial fibrillation will affect the B wave more. It may suggest myocardial ischemia or represent rapid ventricular depolarization. Here is also wrong because ventricular depolarization is represented by QRS complex. So we are left with this option, which is it may suggest ischemia, and this is the correct answer. So in myocardial ischemia, where there is a decrease in blood supply and oxygen to the myocardium, there will be abnormality in the action potential of the cells which are deprived from oxygen. This abnormality will result in inverted T wave. So once you see inverted T wave or depression of ST segment and inverted to T wave, like anything like going down, that is indicative of ischemia. Right? A 55-year-old man presents with chest pain. His ECG show elevated ST segment in lead 2, 3 EVF. If we call back 2, 3 EVF, these are the leads which are looking at the inferior surface of the heart. So what does this likely indicate? So we have here the surface, that is inferior surface, and we have ST elevation. Normally, ST segment is isoelectric, means it's on the line, completely isoelectric. But if it is elevated, it indicates myocardial infarction. If it's depressed, it indicates myocardial ischemia. So here, which option here? We have myocardial infarction in two options. So which one is the correct one? Is option B, because it's inferior, 2, 3, and AVF. So the correct answer here is inferior wall. So how we know it? By elevation of ST segment and the wall by the leads. A 60-year-old woman with a history of hypertension has an ECG that show left axis deviation. Which what could this suggest? So normally the axis of the heart is towards the left. Okay, normally our heart is like that, so it's towards the left. But it can deviate more. Yeah, I mean deviate to left. So if it move like that, we call it left axis deviation, and if it move like that, we call it right axis deviation. So right ventricle, if it's getting enlarged, that will cause the left axis deviation. If right ventricle got enlarged, that will cause us right axis deviation. So left means left ventricle hypertrophy, right means right ventricle. I mean left axis deviation means left ventricular hypertrophy, and right axis deviation means right ventricular hypertrophy. So the correct answer here is option B, left ventricular hypertrophy, and that is supported by the fact that this patient has hypertension. So hypertension as an adaptive response, or like some, because there's too much load on the cardiac muscle on the left ventricle, that will cause the left ventricle to get bigger. And that left ventricular hypertrophy causes the left axis deviation of the heart. A 70-year-old man experiences palpitation. So he has palpitation, means the heart rate is high. His ECG display irregular. The rhythm is regular. Heart rate is 160. So it looks like tachycardia because the rhythm here is regular. Regular rhythm rate is like 160. It's high. It's more than normal, but it's not like flutter, which reach to around from 200 to 300, or fibrillation, which can reach from 300 to 500. So this is just a tachycardia. So, and this also supported by the fact that the rhythm is regular. Okay, this means for each B wave you have a QRS complex. But here the QRS complexes are getting narrow. That is because the rate is quite fast. So what is the most likely diagnosis? So here it's supraventricular tachycardia, means so this is a tachycardia which is because of because it's the source of it is the atrium. So that is supraventricular tachycardia. What support is that? Is the fact that the rhythm is regular and the QRS complex are narrow. An ECG of a 25-year-old athlete shows sinus bradycardia. What does it mean, sinus bradycardia? Bradycardia means heart rate is low. We see here the heart rate is 50 beats per minute, so it's lower than normal, which in young adult is around 60 to 100. That is a normal heart rate. So here is less than that, so it's bradycardia. Sinus means the pacemaker is normal. Means the pacemaker is SA node. Okay, so what does this suggest? So this is athlete. So we know in athletes because they have high vagal tone. Vagus nerve, which is supply heart, causes decrease in the generation of action potential from SA node. So they have high vagal tone, means they have high resting parasympathetic activity to the SA node, and that causes their heart rate to be normally lower than non-athletes. So this is actually a normal finding in athletes. The reason for it is high vagal tone. High vagal tone means high parasympathetic stimulation of SA node. A patient's ECG show prolonged BR interval greater than 200 milliseconds. What is this indicative of? Okay, as I mentioned earlier, the normal BR interval is 0.12 to 0.2 seconds. So here it's greater than 200 milliseconds, which means if it's we have like only this, like for HP we have QRS complex, but only we have prolonged or delay in conduction between the atrium and the ventricle. This is an indicative of first degree heart block. Second degree heart block, we will have like missing beats, like we have like 2B, 1 QRS. So means for each 2 impulses, only one of them reach to the ventricle, or for each 3, we have 1 reach to the ventricle. So that will be the second heart block. Third heart block, it means like complete block. So E between atrium and ventricle means atrium work on its own, ventricle work on its own. So when you look at B waves and QRS complexes, you see they are not related together. For Wolff Parkinson White syndrome, here we have actually short BR interval, not long. So the correct answer here is first degree heart block. A 50-year-old smoker showed deep Q waves in lead V1 to V3, and what does this likely indicate? As I mentioned earlier, V1, V2, septum, V3, anterior, there is actually overlap between the leads which represent the anterior and the septum. So from V1 to V3, we can consider it as an anterior surface of the heart. Deep Q wave. Deep Q represent is a feature for myocardial infarction that is old. So recent myocardial infarction or acute myocardial infarction, we see ST elevation. Old myocardial infarction, we see deep Q waves. So here is it, the answer here is myocardial infarction. So we have 2 myocardial infarction here. We have old anterior or acute inferior. So this is, of course, not inferior because these leads are anterior. So it's anterior, and deep Q wave is a sign for the old myocardial infarction. So it's old because of deep Q, and it's anterior because of V1 to V3. A patient's ECG show a sawtooth-like flutter, waves at a rate of 300 beat with a variable ventricular response. What is the most likely diagnosis? That is the feature of atrial flutter. And even C is a question, we have a flutter here. So this pattern of sawtooth-like pattern is a characteristic feature for the atrial flutter pattern in ECG. Atrial flutter, that is where the rate of atrium ranges from 200 to 300 beats per minute. And of course, not all of these beats will arrive to the ventricle, so there will be some sort of block also present, like maybe 2 to 1 or 3 to 1, means for each 2 impulse we have only 1 reach to the ventricle, or for every 3 we have only 1 reach to the ventricle. So anyways, this characteristic pattern of sawtooth-like pattern, which indicate a high rate of atrium. Okay, so you can observe it in the B wave that indicate atrial flutter. A patient's ECG show ST segment depression, T wave inversion. I mentioned that earlier. Okay, in leads B4 to V6. Okay, so ST segment depression, T wave inversion. So this means ST, you have B, you have Q, R, then S like this, T. So you have depression of ST segment, and you have inversion of T wave. That is characteristic for ischemia. Okay, that feature is characteristic for myocardial ischemia. So the correct answer here is ischemia. In pericarditis, we see ST elevation. In hyperkalemia, we see tall beaked T wave. In digitalis, it will be scoping of ST segment.